This article is a review of therapies for COPD patients that actually reduce the risk of mortality. My name is Dr. Matthew Mintz. I'm an internal medicine physician, primary care physician in Bethesda, Maryland. And the title of this article is Reducing the Risk of Mortality in Chronic Obstructive Pulmonary Disease with Pharmacotherapy, a narrative review that's going to appear in the February 2023 edition of the Mayo Clinic Proceedings. So chronic obstructive pulmonary disease, or COPD, has both a high prevalence, a high morbidity, and a high mortality. It's actually the 5th leading cause of death in the United States. And there are some therapies that have shown to reduce mortality, such as smoking cessation and oxygen therapy. But most of the agents that we use, essentially inhalers, are really to reduce symptoms. And however, there are more recent large randomized trials looking at a patient population in COPD patients that found a signal for mortality. So myself and my colleagues were really interested in, could pharmacotherapy be effective not only for reducing symptoms and exacerbations in COPD patients, but could it reduce mortality? So this is a narrative review of all of the studies in COPD patients that have looked at pharmacotherapy or various different types of inhalers and see what the effect of mortality was, usually as a secondary endpoint. So it's a narrative review looking at all the studies. 2 of the more recent studies were very large studies looking at triple therapy, a combination of inhaled corticosteroids, long-acting beta agonist, and long-acting muscarinic agents. There were 2 very large studies, one called the IMPACT trial and one called the ETHOS trial, which both had a very strong and statistically significant improvement in mortality. And some of the main points are that one, triple therapy in particular seems to be advantageous or effective in reducing the burden of mortality in patients with COPD. And again, the patient population are those patients with moderate to severe COPD who have had a history of exacerbations. The main benefit was reducing exacerbations, or the main benefit from mortality seemed to come from reducing exacerbations. Also, that reduction in exacerbations seemed to come from the inhaled corticosteroid component of the inhaler therapy. The other thing that we focused on is trying to put it into context with other interventions that we commonly do in primary care. So, as a primary care physician myself, yes, I see patients with respiratory diseases like COPD, but I also see healthy patients, and trying to prevent cancer in them. And I also see, patients with cardiovascular risk, or those that have had heart attacks, and trying to prevent, death from heart attacks. So we don't just look in preventing death in patients with COPD, but in preventing death from all of my patients. And so when we look in that context, one of the ways that you can kind of compare these things is to looking at the number of needed to treat. So number of needed to treat is essentially a calculation. How many patients would you have to treat to save, in the case of mortality, to save one life over that period of time? And so in these large randomized trials that I mentioned, the triple therapy trials for COPD, the number needed to treat, depending on the study, was between 105 and 147 patients. And that's a very robust number, meaning it doesn't take that many treatments to save one life. And if you put it in context with some other things that we routinely do, like, so for example, mammography, the mammography is the number to treat is much higher than that. Let's look at something like hypertension, like treating patients with high blood pressure medicines, or treating patients with statins. It's double that, almost more than double that, 278 to save one life. And so this is something that we do, pretty much every day. So it's really in the context of life-saving interventions, treating a moderate to severe patient with at least triple therapy or something that contains an inhaled corticosteroid is on par with treating patients with hyperlipidemia and hypertension with agents to do that, or treating patients who smoke, getting them to stop smoking. So on par or better. So that's really the context of the article. Mainly 2 points. One, that there are therapies not only that reduce symptoms but can actually prevent death, particularly reducing exacerbations using an inhaled corticosteroid. And that two, it's really on par with some of the interventions that we in primary care do on a regular basis. So what this finding means for patients is that in addition to other things that we know, like stopping smoking, or for patients who are very severe, using oxygen therapy, there are other things that they can do with the medicines that they normally take to prevent a death. So, and again, it seems like the mortality benefit was driven by reductions in exacerbations that seem to benefit most from inhaled steroids. So if you're a COPD patient and you're on just bronchodilators, and those bronchodilators don't contain an inhaled corticosteroid, adding a combination therapy, a triple therapy, for example, with an inhaled, which contains an inhaled steroid, not only may make you feel better, not only may reduce your risk for exacerbation or hospitalization, it may actually save your life. So for future research, the best case scenario that what we've laid out is enough evidence to, convincingly show that agents for COPD, their pharmacotherapeutics for COPD can save lives. So what's missing is that randomized controlled trial. So mortality is something that's very hard to show. It requires, not just thousands of patients in the studies that I've mentioned, but tens of thousands of patients in order to show a mortality benefit. It's very hard to do those kind of studies. So that to me would be sort of the next step in research, to do that much larger trial to prove beyond a shadow of a doubt that these interventions work. And that would be, I think, one area of research. So I encourage anyone interested in COPD or takes care of COPD patients. Certainly, if you're in primary care like myself, you certainly see patients who have COPD. I think this is a really good review of a lot of the large trials using respiratory agents, looking at some of those outcomes and specifically looking at COPD. So it's almost like a history of what we've done, in COPD to try to, reduce the reduction in lung function decline and improve mortality benefit.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.